Good afternoon, everyone. This is Farahaba Lakhdir. I'm one of the pediatricians in the outpatient clinic, and I would like to introduce Miss Amanda Lavery, who is our coding consultant and has been in this position since 2018. And she works mostly with pediatrics, psychiatry, and family practice. She has a bachelor's degree in biomedical science with an emphasis in genetics and a minor in psychology from Rochester Institute of Technology. In 2017, she became a certified professional coder and is an active member of the American Academy of Professional Coders. She has worked in multiple areas, including revenue cycle, in multiple areas, including insurance follow-up, financial assistance, and fitting. Um, Amanda has been a great resource for our clinic, and she will be presenting today part one of the coding changes in ambulatory pediatrics 2021. Um, okay, Amanda, take it away.
Good afternoon, everybody. As Dr. Lakhdir said, I've been in this position for a few years now. We did have some big changes in 2021, so we're going to try and go over some of those today and hopefully answer some questions. So just as an overview, some of the things that were changed, the 99201, so that's your new patient, kind of level 1 visit was deleted, so we can't use that anymore. And that wasn't used very often anyway, which is why it was deleted. Medical decision-making requirements are now the same for new or established patients. So in previous years, we had history, exam, and medical decision-making to determine our level of service. And they kind of were skewed a little bit if it was a new patient versus an established patient. And now those requirements match. So your requirements for like a 99214, which would be your established patient level 4, are the same requirements as a new patient level 4. Time is no longer based on counseling or coordination of care. So it's based off of the total time of your total time for the visit on that data service. And we'll talk a little bit more about that. And then finally, we have a new prolonged service code 99417. So to start with time, I think that's probably one of the biggest changes, especially for our pediatrics departments. A lot of time before 2021, we weren't billing so much on time because it had that caveat of being billed off of counseling and coordination of care. Now it's based off of the total encounter time for the data service. So that includes your prep time, reviewing medical records, your face-to-face time with the patient, and then any after visit time that's completed on the data service. So documenting, placing orders, maybe you need to talk with other providers. All of that stuff is now included in your total time. We did have a smart phrase created for you to help you document that if you are going to bill based on time, and that's just .time ENC. And you can see I did put it in here on the bottom, and it tells you the total time of the date and then broken out into the time before, during, and after the visit. If you're billing based off of time, there was a prolonged services code created, which is 99417. And this is billed in increments of 15 minutes. For your commercial and Medicaid plans, that is 15 minutes from the minimum time requirement for 99212 or 99215 or 99205. So that's 60 minutes for your new patient or 40 minutes for an established patient. So if you go 15 minutes over that, then you can add on this prolonged service code. For Medicare patients, which I know is not something you see too often in pediatrics, but there are a few, it is off of the maximum time for your new or established level 5 patients. And then the code is a little bit different. It's a G2212. And if you're using the level of service calculator that's built into Epic, it should be dropping these codes for you when you enter your total time for the date. It should drop that prolonged service for you. So let's talk about medical decision-making. There's 3 elements, and in order to bill, you need to meet the requirements of 2 of the 3 elements. So you have the number and complexity of problems addressed, the amount and or data to be reviewed and analyzed, and then finally the risk of complications and or morbidity or mortality of patient management. So within that first element, you have the number and complexity of problems addressed. So a lot of times for pediatrics, I would expect that most people are falling within the level 3 to a level 4 pretty consistently for number of complexity problems addressed. A level 3 is 1 acute uncomplicated illness or injury, or 1 stable chronic illness, or 2 or more self-limited or minor problems. So that's, maybe the patient's coming in for ADHD follow-up, they're not having any issues, they're stable on their medication. That would be 1 stable chronic illness. For a level 4, we have 1 or more chronic illnesses that have progression, side effects of treatment, or 2 or more stable chronic illnesses. You have a new undiagnosed problem with uncertain prognosis, or an acute illness with systemic symptoms, or an acute complicated injury. For level 5, especially in, I think, the kind of general pediatrics, if you're hitting a level 5, you're probably hitting it more often based off the time you spend, probably more so than the complexity, although there are, of course, cases that you will hit that, which is 1 or more chronic illness with severe exacerbation, progression, or side effects of treatment, or 1 or acute chronic illness that poses a threat to life or bodily function. A just general example would be if you have a patient come in and you need to send them to the emergency room to be evaluated. Maybe they're having some kind of asthma attack or something like that where you're not able to get their breathing where you need it to be and their oxygen levels where they need it to be, then that would probably be something you would see a level 5 as. But otherwise, based off of time, you could definitely meet that in any of your specialties. For data, this is probably one of the most confusing portions of the new guidelines, is just figuring out what falls into what category for data. You'll see that for level 1 or level 2, there is really no data required. For level 3, you're going to hit that pretty easily in pediatrics because the assessment requiring an independent historian is probably 90% required in pediatrics. You're going to have a parent, grandparent, guardian, someone there that's giving you probably a more reliable history than what the patient is able to give you. So right there, you're kind of going to always hit that 3 if you have someone else in the room that's telling you about the patient. Times that I maybe not would accept that is if you have an older patient, 16, 17 years old, that can give you an accurate description of what's going on, then maybe we wouldn't accept that as an independent historian because the patient is capable of doing it. If there's limitations because of a mental health disorder and they can't communicate, or then that would still qualify as an independent historian. For tests and documents, we see a lot of MCHATs, ASQs, Vanderbilts, those kinds of things in pediatrics. Those we cannot count towards data for medical decision making because they are separately billable. So anything that we bill out separately and are reimbursed for, because we're already receiving reimbursement for it, we can't count it again towards our data for medical decision making. So if your site runs specific labs and your site is being reimbursed for those labs, then we don't count those towards the data element. If you're just ordering them and the patient is going to Quest to have them drawn and you then review the results later and we're not being reimbursed for it, then that is something that we would count towards data. And the same with our Vanderbilts and ASQs, MCHATs, because we're going to bill out for those and we're going to be reimbursed separately from the office visit, we don't count that towards our data. For a level 3, you only have to meet one or the other. So you might have the independent historian, or you need to meet one out of two, or any two of the following external notes from a unique source. So that would be, if it's a different specialty, even if it's within Carilion, that would still be an external note. If it's somebody within your office or the same specialty, so if they went to Peds Botetourt and now they're coming over to Jefferson Plaza, we wouldn't count that as external because they're the same specialty. But if you're at Peds Jefferson Plaza and you're reviewing the notes from the developmental office, that would be a different specialty. So we would count that as long as you've documented that you've reviewed those notes. And then you could use each unique test. So if you're ordering multiple labs that your office does not result, then we can count those as well. For a level 4, it does go up a little bit. So you have to meet the requirements of 1 out of at least 3 categories. So again, you have any combination of 3 of the test documents or independent historian, or discussion of management or test interpretation. So this would be discussing how you're going to proceed with a patient with an external physician. So it cannot be anybody that's within the same office as you or that you work with regularly. It would need to be some, kind of an out of the ordinary. I need to talk to the developmental because they're going to defer medication management to me, but I have some questions. Stuff like that would be billable, but anything that's within your office or somebody, even if it's a specialty that works within your office, that would not count under the discussion of management. And then here's the requirements for a level 5. Again, it's going to go up a little bit more. We have to meet 2 out of the 3 categories for the testing, independent interpretation of tests, or discussion of management or test interpretation. So a lot of times these aren't going to be met within, especially general pediatrics. In your specialties, you may have some of this, but it all needs to be documented. So if you're doing an independent interpretation of an X-ray, you have to document it. You cannot just pull forward the radiologist report. You would have to document your opinion of the report, which a lot of times physicians don't want to do because they're not a radiologist. They're just going to go off of what the radiologist is saying. So that would be up to you whether or not you feel comfortable with that in order to build at level 5. Medical decision making, and the last category we have is risk. So for 99202, for our level 2s and level 3s, you can see that the AMA did not give any examples for level 2 and level 3. So it really is kind of up to the provider to determine what you feel is the risk for the patient of complications, morbidity, or mortality of a patient management. I can say in previous years before the 2021 guidelines, for level 3, we were looking at things like over-the-counter medications, physical therapy, occupational therapy, things like that, things that you still were assessing that they needed, but wasn't posing any kind of real danger to the patient. For a level 4, we do have some examples. So that's prescription drug management is probably the biggest one that we see. And that includes new prescriptions and refills. So if you are having that ADHD patient come in who's stable on their medication, you're still assessing, even though you're just going to refill the medication they're currently on, you're still doing that assessment of, how is their weight gain? How is their appetite? How is their mood? You're still assessing to make sure that that medication is appropriate for them and that their dosage is appropriate. So we still count refills under prescription drug management. Decision regarding minor surgery, decision regarding elective surgery without identified patient or procedure risk factors, and diagnosis or treatment of significantly limited by social determinants of health. So level 4, there's definitely some moderate risk involved. And that would be, those are just examples. So those are not the only things that we would see fall into those categories. And the same with level 5. They did give some examples, drug therapy requiring intensive monitoring for toxicity. So that might be something like chemotherapy. We would consider that under a level 5. Decision regarding emergency major surgery. Decision regarding hospitalization. That's where we would talk about sending the patient to the ER. This is no longer something that you can treat in your office and you need to escalate care. We would count that under kind of a decision regarding hospitalization. It does not mean that you're having the patient admitted. It means that you're escalating the care of the patient off of what you can provide in your office. The AMA has come out and said that really it's up to the provider to document the risk. So if you put in your note that this patient was a moderate risk, that you had moderate risk for decision making, that's what we go by. As coders, we have to just go what's in that note for that data service. And they have said that if the doctor feels that they had moderate risk, then we are to trust that because we are not clinicians. It is up to you guys to determine the risk and put that in your note. So we have examples if it's not documented. And obviously the more you work in coding, you read a lot of medical records and you kind of get to know where providers feel risk is falling, but it does help, especially now with the level 2s and level 3s where we don't have any kind of examples, to know where you feel that risk is. Okay, so that's just kind of a basic overview. Is there any questions about that you guys have for me on the new guidelines?
Amanda, can you talk a little bit about when working with residents?
Sure. So with the residents, we're asking that you bill based off of medical decision making. Right now, we have reached out to all of our payers and are not getting really great responses on whether or not they're allowing us to bill on resident time. Previous to 2021, the answer was always no, we couldn't bill on resident time, but there is some wording in the AMA guidelines that make us think that it could be possible based off payer, if the payers allow it. So right now we're asking that for medical decision, you bill on medical decision making. If you are going to be in the room the whole time and kind of dominating the visit, especially with some of the newer residents with your interns, then you could document your time spent. But right now we don't have a clear guideline of whether or not it's going to be allowed. So to protect you and the organization, we've asked that we still bill based off of medical decision making, if that helps.
Also, when adding an extra E&M code to a well check, in that case also you would just use medical decision making, correct?
Correct. So because a preventative visit doesn't have any kind of time attached to it, we cannot say that we spent, you know, we had a 30-minute time slot and we spent 20 minutes on the preventative and we spent 10 minutes on the acute visit. Because there's no time attached to a preventative visit, we do not bill based off of time for those add-on codes. We would just bill off medical decision making to add them in.
And then we should bill whichever would code higher, correct? So either time or medical decision making, but whichever we can get higher.
Correct. Yes. Always code to your advantage. There is nothing that says that you have to take the lower. You can always code to whatever is higher. And that's how, when we're working like the telehealth visits, or if we go in and review your charts for an audit, we're always going to go with the higher level. So whatever's more advantageous for you. And I will say for time, if you're using time to bill, you have to put the smart phrase time E&C in your note. You can't just put it in the level of service calculator because that's not actually part of the medical documentation. So we can go in and we can see that you used it, that level of service calculator. But if your note was sent to the insurance company for, support to support your billing, they wouldn't see that level of service calculator. So they're not going to see the time. So you have to use that time smart phrase. But definitely code to whatever is going to be higher for a level of service.
And for the independent historian, do you always have to document that you obtained the history from an independent person other than the patient and the reason?
If your patient is older and it's somebody that should be able to give you a history and for whatever reason they're not, I would definitely document why you needed the history from mom or dad or grandma. If it's a 3-month-old, then it's kind of intuitive that your 3-month-old is not going to be able to tell you what's going on. So in that case, I wouldn't say you wouldn't have to necessarily support why you're using an independent historian, but I think it's always smart to document who the independent historian is. So, patient presents with mom for visit, or patient presents with aunt for visit, or foster mom. So that if that's more on a legal side, but if you ever had to support your documentation to a lawyer or why you chose certain diagnosis codes or where you got your information, you have that supported in your note already of who provided that information. So there's never a question of who came to the visit with the patient.
All right. There's some questions from the audience. So Dr. Parmeshwar is asking, what type of documentation is needed for social determinants of health? Please give examples.
Is she talking about, and I'm guessing the data part?
Yes, the social determinants of health.
So for that one, it's kind of a gray area, if I'm being honest. They didn't give us a lot of guidance on it, but I would document whatever you can because we no longer use the old guidelines of a full history and exam. We're not looking the social history, kind of those social determinants of health kind of fall under that social history. So you're probably already documenting them. Like, are they low income? Are they exposed to other factors? Like if they have asthma and they're in a home where they're smoking, things like that. I can try and find some more concrete examples to send to you from the AMA or APA. But that's really what they're looking at, is if there's other issues that might not necessarily just appear on like an exam, like smoking in the home when they have asthma. Does that help?
Yes. And then the other question that Dr. Parmeshwar asked, can the time calculator only be used for the day of service?
Yes. So it has to be the time when you're calculating time, it has to be on that date of service. It's not like a 24-hour window. It is, if your appointment was on May 17th, it's any time you spent on May 17th. So if you started pre-charting at 10 o'clock the night before, we can't count any of that. And if you finish your documentation the next morning, then we can't count that time. So it's any time on that actual date of service that you see the patient.
All right. So if we don't complete the note that day, then you cannot use the time that you would have spent on the note.
Right. We can use any other time that you've spent that
Right.
day, but if you don't complete the note on that date of service, then you just wouldn't count that. You wouldn't document that time as part of your total time for that encounter. So if you still had, a significant amount of time pre-charting on that day, or you had a long visit in the room, maybe you really did have a 40-minute face-to-face with the patient. Mom had lots of questions that you had to go over, then you would still want to count that time, and you could potentially still have a higher level billing based on time You just wouldn't count the time that you didn't spend that day.
And, um, and then Dr. Tiffany's asking, do I have to use your smart phrase or do I just have to use a smart phrase? And I'm thinking that's for the time calculator.
If you're talking about the time calculator, then it was created with compliance, and so they do recommend that you use the the time enc to bill based off of time. I'm not going to say that it's 100% you have to absolutely use it. I'm going to say it's very, very highly encouraged. And I can't promise that you won't get an email from your coding consultant if you don't use it, recommending that you do. So,
Right. For the medical decision making, the level of service calculator, do you have to when you're coding when in the chart, do you always have to use that?
no, that's just a tool that was built in to try and help with the transition. If you are feeling comfortable with the new guidelines and you have seen, you see a lot of the same types of visits, so you're probably going to get pretty comfortable with this is a level 3, this is a level 4. You don't have to go through that step every time. You should be able to just choose your code and drop it. You shouldn't have to use the calculator every time. It was more just a tool to help transition.
Well, thank you, Ms. Lavery. It was a great presentation. Next time, there will be a part 2 in which I will be presenting some cases, and then we can discuss what level of service we would quote those at. So we'll see you on June 21st.